It's an absolute pleasure to be here to share with you one of my lifelong dreams to prevent cardiovascular disease in all populations in the world. First of all, I would like to thank my good friend Sunita Dodani, Dr. Mehrotra and Dr. Meena Murthy for taking the efforts to put together this conference, which is of importance for the population of South Asians which have been neglected for a long time. I also admire the work of Sri Krishna Nidhi Foundation or SKN Foundation, and knowing how it has been generated, started, is quite inspiring. Let me start with a personal story because I was quite impressed with the 4 patients who talked about this morning, their personal stories. I lost my father when I was 5 years old due to heart attack, and he died in Malaysia, so I have no recollection of seeing him. As a child at 5 years age, my desire was to find a solution so that no kid will lose its father or mother for that matter when they were children. So that is what is driving me, still driving me and going on. I like the title that they have given, Advancing South Asian Cardiovascular Health, Understanding Unique Risk Factors. These are all common, I understand. And the last part is, and health needs to promote shared decision making. It's absolutely important to share the decision with your patients, because we can prescribe, we can tell them and treat them as if they know nothing. But once they understand, half the problem is over. And then with them, we can have the cooperation and the issues of adherence to treatment or the recommendations will also be solved. So let me quickly go over, because this fact has been talked about last night, today again. South Asians are the people from the subcontinent, and Sri Lanka, Bangladesh, Bhutan, India, Maldives, Nepal and Pakistan, they cover about 1/4 of the global population, roughly about say 25%. And if you look at the CVD burden, cardiovascular burden, in each of these countries, they account for nearly 40% of the entire global CVD burden. And then if you look on the rightmost column there, you will see the hypertension prevalence. Sri Lanka has got about say 21%. You look at India, where many of you in this room are originally from, is around whopping 31%. And Nepal has got about say 34%, and Pakistan is about say 25%. And this is quite a staggering number. And in this conference, let me just go on to the next slide. We talked about several risk factors, you all heard. Only thing that the organizers, perhaps they didn't have time, or maybe it is not a case anymore in the US, is smoking. Because perhaps South Asians in North America either have controlled smoking or not smokers at all. If that be the case, well and good, keep it up. And we have addressed in this conference many of these things, and high blood pressure is a topic which I will be trying to cover within the next 15 to 20 minutes. So this is what is called Healthy Heart Kit. It was introduced and worked by a set of experts across Canada to prepare something that can be used for the professionals and also to be shared with the public, so that the patients can also understand. It has got all the 6 risk factors that we are talking about here, and on the right hand side, one has a flip open page for an algorithm for one of the risk factors in this case. So this is the management of smoking. So this tells you what to do and what not to do, and then there's a recommendation for the patients. So hypertension in South Asian countries, the prevalence of hypertension is about 27%, which is defined as 140 over 90. And pre-hypertension, taking 120 to 139 over 80 to 89 is at 29.6%. And when you look at the range, that is the range of the prevalence in different parts of the South Asian countries. We heard in the morning from the diabetes point of view that there is a higher prevalence in urban areas than in rural areas. And so is the case in hypertension too. Meta-analysis, which is a term that we use very often, but from the layman's point of view, meta-analysis is pooling many studies and then finding the effect. And then it shows an association or the odds ratio of more than 1 of hypertension with male, sex, alcohol intake, low food intake, diabetes, family history, high cholesterol, high triglycerides, obesity, and particularly central obesity and high salt intake. There are some of the risk factors we can't change, like the genetics, which we heard a little earlier, and we are trying to understand more into how we can treat the genetic aspect. And then whether you become a male or a female, you cannot. It's all pre-chosen. And the age is a factor that we cannot change. But all others we can change. For example, smoking. We were not born with a cigarette in our mouth. That is an acquired habit. And likewise, when we were back home, we were never introduced to McDonald's or the Big Mac. So these are all acquired habits. And we were not drinking pops in the older days or even most cases, but that's again acquired habit. So a lot of it is what we made of ourselves, and we created problem for us, and then we are suffering. And if you look at the rural-urban divide in terms of hypertension prevalence, in India, 30% is the average. We can see the dotted vertical line. And in most of the rural areas, it is on the left-hand side, while in the urban areas, it is on the right-hand side. The only exception is in the eastern India, which is slightly onto the right. And more importantly, as an epidemiologist, we always would like to count numbers and say what is the prevalence, what is the incidence. What is important is how much are we able to control? How many people have we cured? Are we able to control hypertension? That is an important issue. If you look at the left-hand side, about 25% in the rural and 33% in the urban have hypertension. And awareness is only 25% in rural and 42% of urban of the numbers above. And then among them, only 25% have been treated in rural areas and 38% treated in urban areas. And only 10% of rural and 20% of urban are treated and controlled. So the last number is misleading just by looking at 10%. It is a 25 of 25 of 25 of 10. So it is really very, very small control. So we need to increase the numbers at all levels to improve hypertension control. So since I'm the only speaker speaking on hypertension, not just diet alone, would like to touch upon what is called isolated systolic hypertension. Is Dr. Pichumani here?
Yes.
He mentioned about 40 years ago when he did some studies, the life expectancy of people is around 40 years. But fortunately, thankfully to advancement of medical sciences and advancement of global understanding, the life expectancy of Indians have gone up to 68 in India, and it is much more than 75, 78 in the Western world where we have adopted to come. So now as we live longer, we will have a different set of hypertension, particularly the people over the age of 60, and that is called isolated systolic hypertension, which means the systolic blood pressure goes up while the diastolic blood pressure is coming down. So in other words, the total mean arterial pressure is getting higher, and that is a risk factor for older people, especially the South Asians. So the increase in blood pressure changes with the age, mostly associated with structural changes, which we refer to as large artery stiffness. And there are some studies done with respect to which drug is able to control isolated systolic hypertension in the elderly. And here is a list of studies, and there is a reference at the bottom by Pinto on Postgraduate Medical Journal. So these are all the well-documented elderly study on hypertension, and as you can see, in most cases, the treatment has benefit. So isolated systolic hypertension can be cured and must be cured so that the people don't have heart attack due to hypertension. And here is a study in sodium excretion from a Bangladeshi population, and these are CKD patients, or chronic kidney disease patients. And in these people, when they reduced sodium levels, and the reduction in blood pressure is quite significant, either during daytime or during nighttime. Intervention groups are in the hatched bars. So you can see during daytime, there is a reduction of 9 millimeters of systolic and 4 millimeters of diastolic, and in the nighttime it comes even significantly higher. On a population basis, even a 2 millimeters of mercury decline is good for the overall health. On an individual patients, we want the numbers to really come down below 140 over 90, which is a generous number, and 130 over 80 in case of a person has got another risk factor. So this is on CKD patients, and particularly I am talking about sodium here. So sodium reduction in a patient shows a remarkable improvement. And here is some studies, thanks to Dr. Salim Yusuf and his large team who is working on it. And if you look at the blood pressure by sodium excretion is proportional to the sodium intake. And here hypertension on the x-axis and no hypertension. The numbers are pulled here, and a total of 133,000 population they have studied in a large study. On the left hand side is systolic, on the right hand side is diastolic. If we can look at people with no hypertension, it's in blue color, it rises with sodium intake, but not really bad. If you recommend 140 as your recommended systolic, it doesn't go over 124. Whereas if you are already hypertensive, it goes from 144, it goes as high as 155, 156. And so is the diastolic. So the point that Dr. Yusuf and his colleagues were trying to derive is, can we universally tell everybody to cut sodium? Because sodium is required for you to have some taste, but universally you don't want to take more than 5 grams of sodium a day. 5 grams of salt, 5 grams of salt is quite generous per person. If you are a family of 4 people, that means you are talking about say 20 grams of salt. If we are using more than 20 grams of salt in the household, that means we are consuming more salt. But as individuals, if you are not hypertensive, I wouldn't say a blank check that you don't have to be worried about sodium, but it is not as bad. But if you are hypertensive, be careful. And this is very well shown by one other data from Dr. Yusuf's group. If you look at the overall of these 133,000 people, you see the normal U-shaped curve, which shows below a certain point it's coming down, and there is a dip, and then the J curve goes up. So only the first part we always talk about it. Anything more than the so-called 4,000 milligram or 4 grams is bad. But if you tease out people who are hypertensive in the middle and people with no hypertension on the right, people with no hypertension, you don't see that significant effect. So again, I want to caution, I'm not recommending people to take salt if you are not hypertensive. But overall, taking less salt is good, but you don't need to be too alarmed. If you have got any other risk factor, definitely salt is going to aggravate the situation. And then moving on to atherosclerosis, you heard more about it earlier, how these plaques deposit throughout your veins and in your arteries, and which blocks. And then we heard about the people having heart attack, and the blockage happens once the total closure through the arteries. So this is also aggravated by increased blood pressure. And then again, Dr. Yusuf's study, which I am quoting very liberally here, he looked at from 3 different economic viewpoint, from the high income countries, from middle income countries and low income countries. And they rank ordered various cardiovascular risk factors. If you look at overall, hypertension comes number 1, and then low physical activities goes as number 10. But if you tease out for different economic countries, in high income countries, high non-HDL cholesterol, I am glad that Dr. Reda spoke about the non-HDL cholesterols and the impact of non-specific HDL cholesterol. And if you look at the middle and low income countries, hypertension comes as number 1 cause of heart disease. And coming back to the last few minutes on the diet and hypertension. First of all, we believe in a lot of diets by reading the internet, by people promoting it. Not all of them are good for us. What is important is you have got to take a balanced diet. So don't be carried away by somebody saying, well, I took this diet, I lost 20 pounds, or my blood pressure went by 30 millimeters. Some of these tall climbs evaluate yourself. Google is not the main source for us to understand, and we should go for evidence. So, what grows in the native to the land or the region is the ideal diet. We are getting mangoes right in the middle of winter. Is it the right time to get it? Are we living in that zone to eat? And moderation is the key. If you like something, don't indulge on it. But enjoy life, eat everything, but in moderation. We should know when to stop and when to take control. And there is no specific diet for reducing hypertension. There is no magic bullet. And excessive intake of any one kind of food alters the human body system, thus leading to increased atherosclerosis, diabetes mellitus, and also elevated blood pressure. Poor diet is a common risk factor for heart disease and all chronic diseases. When you say all chronic diseases, it is a risk factor for cancer, diabetes, lung diseases, and even the imbalance creates mental health. So balanced diet is recommended for overall good health. So what is balanced diet? A balanced diet gives your body the nutrients that you need. So it should be made of fresh fruits and vegetables, whole grains, legumes, nuts, lean protein, and dairy. I was quite impressed with the lunch that they served today. It's literally a balanced diet. Thanks to the organizer. And you must have seen this one from the Harvard Healthy Eating Plate. So you fill your plate, half of it with vegetables and fruits, and about a fourth by whole grains, and about a fourth by healthy protein. So you choose from the right quadrants. And when you talk about diet and exercise go hand in hand. Diet alone is not going to solve, but you also should need to have exercise. And physical activity and good health, plan a balanced diet and exercise based on your overall goals. Adjust the balance to fit weight loss or muscle gain. And consult your healthcare professional before starting the physical activity. And energy intake must balance energy expenditure. If we eat healthy or the sumptuous food and then sit all the time, so can I ask all of you to stand up for 1 second or 10 seconds, stretch yourself and sit back, please. So in summary, people of South Asian origin have a higher prevalence of cardiovascular mortality and morbidity compared to the global mean. We heard it many a times during this conference. Hypertension rates are significantly higher among South Asians, either in their native land or in adopted countries like where we are now. High calorie, unbalanced diets and lack of exercise make the South Asians susceptible to increased risk of non-communicable disease, particularly cardiovascular disease. Lifestyle changes and behavior modifications are essential for South Asians to attain good health. But before I conclude, I also want to remind all of you about the upcoming Congress in Toronto in June of 2023, talking about World Non-Communicable Disease Congress, looking at all 5 major chronic diseases such as heart disease, cancer, diabetes, lung disease and mental health. And the call for abstract is out, and please look into our website, and would like to see more of you. And the message that has been generated in this conference must be promoted throughout the world so that the South Asians will have a better health and the Congress is not a Congress only on silos of either heart disease or cancer. It is across the spectrum, looking at reducing the inequities and the impact of NCDs, looking at the impact of climate and environmental changes to the NCDs, and NCDs across the human lifespan, as well as identifying multi-morbidity and multidisciplinary solution to reduce the chronic disease, as well as new research, perspectives, policies, technologies, such as artificial intelligence, big data, how they can help us. People like my colleagues, Dr. Raj Gopal and everybody, we were looking with small sample size, worked on data with a limited cohorts. But in today's technology, we are able to pool much more data and come up with solutions at a much faster rate. And improving governance and multilateral collaboration and rapid scientific exchange. Those are the order of the day. And I hope to look forward to see many of you in Toronto with a welcome. Thank you.